this was like this was pretty taut here. So I was suspecting an incarceration at the site of the scleral tear. Now this was the surgery. There was a total chamber hyphema, and despite repeated washes, it was still continuously oozing and hence filling up again. So I did a lensectomy, placed the infusion, I made sure it's in place, and went in. And this is for most of us who operate on trauma cases, this is like a textbook finding. We have dense, multi-layered vitreous hemorrhage, clotted blood, and we are always going in with a lot of trepidation because we don't know what we are cutting, whether it is vitreous or retina. We just you just get the feel of the tissue. You start seeing the retina there, and if it moves very fast and this thing, it's probably vitreous. So like you can see, this is a partial PVD that has happened, and you can see the retina underneath it, and it is already detached. So while I was clearing the vitreous hemorrhage, it was obvious that it was still bleeding because it's a congested eye after all. There were some breaks, inferiorly large ones, and as I cleared the vitreous hemorrhage, this is the finding that I saw at the optic nerve. There was an avulsion for sure. You can see that there is retraction of the optic nerve head from the ring, and I filled PFCL both because the retina had a GRT almost 360 degree as well as a continuous bleeding. So now here there was this site of incarceration of the retina with a lot of scarring at the site of scleral tear. So what I did was I isolated the scar from the rest of the retina. You can see that this is the retina, and I have isolated the scar to prevent reproliferation. And as I was doing the retinectomy, I was finding that it was still continuously bleeding. The choroid was bleeding, the retinectomy margins were bleeding. So I have left the globe PFCL field. I operated on this last week, and I'm going back to see after 2 weeks, at which point I'm sure it will be much easier to handle. So in trauma, you have multi-layered, thick, clotted vitreous hemorrhage. The light pipe is difficult to visualize, especially the initial part where it is obscured. We don't know what we are cutting. Surprises, it's a Pandora's box, so it can be anything inside. It can have an RD, it can have incarcerated retina in the scars like I showed. There can be a foreign body, there can be infection, endophthalmitis. There can be ruptures of the choroid with scarring, and of course, like in my case, optic nerve avulsion. So the visual prognosis has to be explained to the patients in no uncertain terms. In a trauma, it is a Pandora's box. You can have anything. So this is my next case. We'll come to the non-traumatic vitreous hemorrhages in young people. This is a 16-year-old boy with diminished vision in the left eye more than the right eye. Right eye had a vision of 260 and left had half by 60. There were a few granulomatous KPs in both the eyes. Now this was the right eye. We could see some chorioretinitis, and they were straddling the veins. There was vitreous hemorrhage in the right eye, and there was this kind of vitreous hemorrhage in the left eye with this severe chorioretinitis. In fact, it is more of retinitis with severe cuffing of the supratemporal vessel, the peripheral vessels, and the nasal retina, showing some kind of frosted branch angiitis picture. So we did do a uveitis workup, and we started on systemic steroids. After 2 days, there was a slight improvement with steroids. The only thing that came up positive was a MAN2 test. As we know, according to the courts, this is grounds for starting ATT anyway, because tubercular retinal vasculitis is one of the hallmark diseases of ocular tuberculosis. So with steroids, we can see that the cuffing has reduced. Even this has started developing hemorrhages. The frosted branch angiitis is getting better. 1 week later, we also started ATT in view of the diagnosis of TRB. So we decided to taper by 5 milligrams every week, and this was the picture. We thought he's slowly getting better, but at 1 month of steroids and ATT, the right eye, although it improved, the left eye had a sudden diminished vision with counting finger close to face. We planned to observe because there was only a partial PVD on the B scan, and planned a vitrectomy after complete PVD. So this is what happened. We could see the disc hazily, but the vision was very less. So Rohan, I'm sure you remember this case. He actually managed this case from start to finish, including the surgery was done by Rohan. So this was vitrectomy and endolaser, and this was air filled, and this was post vitrectomy, and the patient had undergone endolaser for all the areas of non-perfusion that were seen intraoperatively. The vasculitis started getting better. The patient continues to do well on ATT and low dose steroids. This is at 3 months follow-up. So what I want to say is retinal vasculitis can have simultaneous presentations of all the stages of vasculitis, ischemia and neovascular stages. They can all present together. But it is also important to know that not all vitreous hemorrhages are because of neovascularization. Like in this case of post-fever retinitis, who sometimes develop vitreous hemorrhage, and that could be because of neovascularization. It could also be because of inflammation inducing posterior vitreous detachment, or it can be a detachment causing avulsion of a venule, a taut venule. This is the next case, 31-year-old woman, postnatal day 4. She had just delivered her third baby, and she had diminished vision since the day of vaginal delivery. So this was a case of preeclampsia. Right eye vision was just counting finger close to face. Left eye was absolutely normal. We worked her up. She was found to be anemic with some microalbuminuria and some probably UTI, we don't know. D-dimer was severely raised. So we corrected her anemia and planned a vitrectomy under steroid cover because her D-dimer was very high, and we sought physician fitness. She developed a breakthrough hemorrhage meanwhile, and we saw that her blood pressure was not getting controlled no matter what. Slowly the vitreous hemorrhage became more diffuse, and this nasal subhyaloid hemorrhage started settling down and trickling down, although this vitreous hemorrhage was looking like it is progressing. But it has broken through. So now at this point NVD is visible. So this was on the day of surgery. Post-surgery, we did find intraoperatively that there were multi-vessel or multi-vein occlusions, and this is the post-op picture. She's doing well now. She's about 6'9" and very happy with her vision. This was a consequence of accelerated hypertension, perhaps. I'm still not sure of the diagnosis. This was post-delivery, young woman, multi-vein occlusions, high blood pressure, raised D-dimer. I'm still caught between whether it is post-inflammatory or a sequelae of retinal vein occlusion. This is a very interesting case of a 38-year-old woman with diminished vision in the right eye for 5 months. She's a person living with HIV/AIDS on maintenance therapy for pulmonary tuberculosis. Vision in the right eye was hand movements, and left eye was absolutely normal. And the right eye had large mutton fat KP and broad base posterior synechiae with very restricted view of the fundus. You can see this leopard mottling here with plecoid lesion, and this had attended and another feature of vitreous hemorrhage as well. So we did do her uveitic workup and found that TPHA was also positive along with HIV, as we already knew. So we diagnosed this as a case of syphilitic chorioretinitis based on the investigations, the leopard mottling and vitreous hemorrhage also. Vitreous hemorrhage, I have learned, is caused by syphilis as well. So now this patient did better inflammation wise. The granulomatous KP and the uveitis part, anterior uveitis part started getting better. And in fact, it got a lot better with 20 days of IV cephalosporins. But what she developed was progression of the vitreous hemorrhage. There was a large clot here inferonasally, and there was diffuse vitreous hemorrhage, this subhyaloid hemorrhage. So that is a little uncommon. Finally, at this point, she has dispersed vitreous, breakthrough vitreous hemorrhage, which is more diffuse right now, and the uveitis part is nearly resolved. This is the last case of a 19-year-old boy with painless loss of vision in both eyes since a month. So there was history of some head trauma which may or may not be related. He's been treated for allergic conjunctivitis with topical steroids for a very long time and has received IV treatment with antibiotics 2 weeks ago. So both eyes, perception of light and 360 degrees Fanus-like picture with some gelatinous membrane sort of thing at the limbus in both the eyes. This was a fundus examination. Both the eyes images are unclear because of poor fixation as well as vitreous haemorrhage. So the right eye losity was possible, and this diffuse thickening of the inner layers was seen, suggestive of retinitis. And the patient was HIV and HbSAg positive with some mild anemia. Next day he told us the whole story because they are not initially forthcoming of their history. So he is on heart and treated for cryptococcal meningitis. So this was a case of bilateral CMV retinitis with very low CD4 count, and even had the finding of bilateral OSSA. So post treatment with ganciclovir intravitreal, the vitreous hemorrhage started to resolve and he did start to get better. So this was a case of severe hemorrhagic CMV retinitis with vitreous hemorrhage. Now my last slide, like I said, trauma can be a Pandora's box. Infants and children, non-accidental trauma, shaken baby is one of the important causes. Rarely they can be tumors. Vascular retinopathy, we still have to rule out diabetes and hypertension and common metabolic conditions. Post-infection and inflammations, like I have shown. Terson's, Valsalva, we have to ask the right questions and ask them to recollect these histories, and we have to keep in mind blood dysplasia, sickle cell,